I wanted to introduce our two panelists, Dr. Mark Donaldson and Dr. Michael Glick. On a personal note, I've worked with both of these guys many times and for a lot of years. And it's a true pleasure to be able to see you this evening and talk through some of these issues. So welcome, Dr. Glick and Dr. Donaldson.
Thanks.
I also, rather than run through their entire CVs and all their credentials, I thought maybe I'd just say a few personal words. Dr. Mark Donaldson and I have done continuing education courses for almost 20 years now, and I consider him one of my very best friends. He is a dental pharmacologist, and you know, it's just an amazing collaboration to be able to work with not only a friend, but someone who has really elevated my knowledge of pharmacology and continues to do so. He's an educator, an author. You know, this is almost a hobby for him. I mean, you know, he has a job on the other, you know, in the medical side of things, doing consulting, but a true interest in dental pharmacology. And so I wanted him to join us to talk about therapeutics around COVID and kind of what's new and what updates exist. Dr. Michael Glick, I met him, I don't think he even wants me to say it, how long ago it was, but I met him, we were trying to talk about, I think, 95 or early 1996 at the University of Pennsylvania. And he knows this because I've told him this before, but I really consider him a mentor as well as a friend. And so it's wonderful to have him with us this evening. You may know him in his previous roles. He served as the Dean at Buffalo School of Dental Medicine, as well as the editor of the Journal of the American Dental Association. Again, author, educator, speaker. It's just a real honor to have you two here tonight, Dr. Glick.
Thank you, Jason.
So my first question is for you, Dr. Glick. One of the things that's really top of mind in the dental community right now is the resources and tools that we're hearing about for the oral healthcare providers, the whole teams to get back to work. Everybody wants to get back to work. And so we're learning about ways to potentially do that. From pre-screening to social distancing within the office, to taking temperature, to air handling, to PPEs, and to reduced aerosols. But one of the things that I know that you've been working on is how COVID testing can help with this playbook. The idea is that dentists could be looking for testing, you know, additionally testing to help, you know, sort of answer the question, is this patient safe to treat or are they not safe to treat? And so I kind of wanted to get your thoughts around COVID testing, kind of where we are, and potentially does the current tests, whether they be the antigen or the antibody tests, help us to answer that question, which is, you know, are these patients safe or are they not safe? So what do you think?
Thank you, Jason, for that question. Yeah, it's a big concern right now, this whole issue surrounding testing. I should probably start with saying that two types of tests that we can do. We can test for the virus itself. It's a molecular type of test where we look for the RNA of the virus. And the second type of test is an antibody test where we look for the immune response to someone who's been infected. Obviously, the antibody test is for the purpose of finding out if someone has been infected, have they recuperated, and maybe potentially are they even immune. There's no answer to that last one yet, by the way. There's some thoughts about if you've been infected, could you be immune? And that probably is a large issue surrounding dentistry as well. So let me address that one first. There are a lot of different coronaviruses out there. 4 of them cause common cold, more or less. And then we have SARS, 2003. And then we had some called the Middle Eastern Respiratory Syndrome in 2012. And now we have obviously COVID-19. So the coronaviruses have been around for a long time. So when we do the antibody testing today, we have to be very careful that the antibody testing we are doing would truly only check for the antibodies against this specific virus, SARS-CoV-2, and should not pick up our exposure to any previous viruses that are in the same family. So that's number one. Number two, if I look at SARS, we have more information about SARS than Middle Eastern Respiratory Syndrome. the immunity that was conferred by after being infected with that virus was around a year, and then it started to wane. We don't know if it's going to be the same thing for COVID-2, meaning if you get infected, will you even have immunity? And if you have, how long time it's going to last? So if you want to test, for instance, individuals that work in your office and say, okay, you have antibodies, that means you are immune, we can treat anyone, we can treat someone who's infected, not infected, we're not putting you at risk. So I would be very careful, today at least, of using an antibody test to see if someone is immune to COVID-19 virus, to the COVID-19 virus, the SARS-CoV-2. So that's the antibody test. The molecular, the antigen test, the viral test, that's a different story. So if you have the virus, obviously you are infected. And if you have the virus, you have potential to spread the infection to someone else. Now, there are two concerns here. Number one is, obviously, can we actually pick up the virus with available tests? And no test is 100%. Each test has their own performance ability to pick up if someone is infected and not infected. And you also have an issue with the prevalence of the disease, meaning if you have a very low prevalence of a disease, even if you have a very, very accurate test, your chances of getting a false positive response is actually very, very high. I'll just give you a number here, for instance. If the prevalence of COVID-19 is around 0.3%, meaning not even 1%, 0.3%, and you have a test that has a specificity and sensitivity, which is the ability of the test to pick up positive and negative values, is high, let's say 99.7%, you get a positive predictive value, meaning you will get only around 50% chance of knowing if a positive test that is coming back comes from an infected individual or a non-infected individual, meaning you have 50% of true positive test results and 50% of false positive test results. So we have to be very careful, especially with a disease that has low prevalence. Now, we don't know the prevalence of COVID-19 yet. So it's very hard to calculate what is the predictive value, meaning it's hard to calculate what is the answer to the question, I get a positive result. Is the patient truly positive or not? The good news is that a negative result today is probably very sure that the negative result today means that you are not infected with the virus. So if you want to test in order to find out if someone is negative, the tests available today are very, very good. They are almost close to 100%, okay? If you want to do the test to find out if someone is positive, I think we have some concerns. And the bottom line with all this testing is very simple. A test is technically asking a question. And if you ask a question, you need to know what to do with the answer. So if you test a patient and they come back positive, what are you going to do with that answer? What are you going to do with a positive patient? So are you going to treat them? Are you going to treat them differently? Are you going to have different infection control procedures, et cetera, et cetera? Now, and I'm sorry I'm going on and on here, but the diseases we have dealt with until now, and specifically the big ones, the one scary ones, HIV, for instance, was a bloodborne disease. So the problem we had then was, if we get a needle stick, can someone get infected? With COVID-19, which is a disease that is transmitted very differently by aerosol, maybe even by talking and breathing, we should not only be concerned about the operatory itself, we have to be concerned about the front desk personnel. We have to be concerned about people waiting in the waiting room and so on and so forth. And those are issues that we need to deal with before we start doing the testing. What to do with the test result, how to treat patients that are positive and negative. And there are other issues as well, obviously, but those are the ones that I would bring up at the forefront here.
Yeah, and you just mentioned something very interesting, and this is a question I'll go to Dr. Donaldson with, is the idea of aerosols. And we hear a lot about aerosols and that dental offices could be a risky environment. And certainly we know that we create a lot of aerosols in the dental office, obviously from things like handpieces and ultrasonic instruments. But also you mentioned just talking and breathing, and then we know that to be true. And so I'll ask you, Dr. Donaldson, what are you hearing about COVID's ability to last in the aerosol state and potentially on hard surfaces? And then as a follow-up to that, maybe you could talk a little bit about, I know that you have a particular interest in pre-procedural mouth rinses as, as what could be effective for pre-procedural rinse to potentially lower the viral load of COVID. So first, what are you hearing about aerosols and COVID's ability to last in that state?
Sure, and thanks very much for the question. I guess, starting off, we have to recognize that the coronavirus can actually live for hours to days on different surfaces like countertops, doorknobs. In the aerosolized state, of course, it's going to be very dependent on what type of, what kind of airflow there is in the room. We still don't have great guidelines around whether or not the vitality of the coronavirus is impacted by different types of light or heat. Changes in sunlight, how that may affect, again, its sort of ability to exist on hard surfaces for a longer period of time. But definitely if you are around somebody that is infected and certainly they, contaminate certain hard surfaces, that's going to be one of the areas that you definitely want to wash your hands, be very aware of, and obviously, have a high sensitivity to sort of staying away from those. Just some examples, because there has been, in fact, a lot of work done around this. And we know that just as metals, as example, doorknobs, jewelry, silverware, typically the vitality for COVID is up to 5 days. Wood is a little bit lower, which is good, maybe about 4 days on, furniture, decking, those types of things. Plastics, which we see a lot of in not only our home environment, but also our work environment. So packaging like milk containers or detergent bottles, 2 to 3 days. Stainless steel, 2 to 3 days. Cardboard. Now this is an important one because I think most of us have become very familiar with Amazon Prime and maybe even shopping online these days. So those cardboard boxes that are getting delivered to you, they can actually harbor COVID for up to 24 hours. So I do know that there are a lot of people when they receive these cardboard packages that they actually don't do anything with them for at least 24 hours to try to improve their ability to avoid COVID from that type of exposure. Other very specific areas, copper, 4 hours. So that could be with some of your cookware perhaps. Aluminum, 2 to 8 hours. Glass, so our drinking glasses, measuring cups, those types of things, again up to 5 days. So there's a very broad spectrum, if you will. I think what most people recognize is that we don't have good standardization here, and if you suspect that there is a contaminated countertop or something, that again definitely you want to continue to follow universal precautions, good hand washing, good hand hygiene, and just watch, certainly if you are around somebody that's suspected of having the virus.
Yeah, can I add something here about the aerosol? We don't know exactly how well the virus might be transmitted in a dental setting through the aerosol that we generate in dentistry. We're waiting for information. I usually describe it as we're flying the airplane while we're building it at the same time, meaning we learn as we go along here, but we don't know what the airplane is going to look like in the end. If I look at some of the data that come out of Wuhan, specifically the dental school and some dental practices in China, there are very, very few dental professionals that have been infected with the virus. And if there are dental professionals that have been infected with the virus, it's not sure they got it through dentistry. If I look at countries that actually never closed the dental clinics, we have not yet found, or there's not yet been reported clusters of individuals that have been infected by treating patients. So although it's a biological possibility that the aerosol that we generate in dentistry may actually pose a risk to us and people around us, I hope that is not right. I hope it's not correct, but we have to be very careful. So plausibility, absolutely. In reality, as of yet, we have no data if it really is as infectious and as dangerous as we think it might be.
Yeah, and that brings up the question of PPE, I think, right? Well, maybe we'll just tackle that one right now, which is, I think we're hearing a lot about guidelines for PPE, guidelines for what we should be wearing in the dental office to potentially protect ourselves. Again, the thinking is around aerosols, and certainly anybody that's worked in a dental office for any length of time knows that we're used to this. We wear protective clothing, we wear eye protection, we wear potentially face masks, and certainly gloves and masks. So I guess the question for both of you guys is, what are your thoughts around a PPE? Are we talking, you think that N95 masks are the way to go, or you think that potentially level 2, level 3 masks or surgical masks, or kind of what are your thoughts around PPE? I'll go to you, Mark, first.
Well, my experience, as you know, is from the hospital environment. And so from a hospital environment, PPE is essential. And it used to be kind of restricted more to the surgical suite or ICU, or patients that were in isolation. Within the pharmacy department, if we were mixing IVs, then chemotherapy in particular, definitely we had all 5 forms of PPE. I think where we are today is as Dr. Glick was stating, we don't have as much information as we would like to change policy. So I think where we are right now is recognizing that universal precautions do need to be followed. I mean, like yourself, Jason, I go out on the internet, I monitor some of these dental listservs, and I've seen individuals in, spacesuits and negative pressure rooms, and again, we don't have good guidelines around what is effective. I do some work with Dr. Aaron Burry out of Ottawa, and he works the front lines as a dentist in these emergency cases. And one of the things that he commented to me about, in trying to be as protective as possible, not just for him and his staff, but also for the patients, is, really stepping up, just not with the N95, but, all of the garb that's required. And he said, one of the challenges is a typical dental day, maybe you see 15 patients, let's just use that as a number. He said, now when I'm seeing these emergency cases, I'm lucky if I can see 5 patients a day. People don't realize that changing in and out of the different PPE, as well as the amount of concentration that goes into maintaining that barrier type isolation between you and the patient, very, very stressful, and also very, very time consuming. At the end of the day, dentistry, like medicine, is based on relationships, and you are now going to be in a situation where you can't calm that patient, touch their hand, so that interpersonal relationship that we have with patients is also being grossly affected here. So I'm not sure what the right answer is yet. I think some of the regulators, NIOSH, the CDC, the FDA, even OSHA, still trying to pool all the data. And as Dr. Glick correctly stated, we just have not seen these major clusters in other sites where the oral healthcare professionals could be at higher risk. But I think an ounce of caution is always the direction that we want to go in. Michael, I'm sure you've got a better answer.
No, not a better answer, but I will build on your answer. So, Jason, as you know, we are talking about 2 different types of masks. We talk about the N95 and the regular surgical masks. There is a difference between them, and the surgical mask probably protect the person I'm speaking to, and not myself if I'm spoken to wearing that mask, if I've been exposed to the aerosol, while the N95 protects me in both directions. And that's a big difference between those 2 masks. So I believe that the future dentistry will be the N95 or N95 equivalent is probably going to be standard.
Yeah, and take that a little step further, guys. Because now the recommendation is wearing masks at all times during the day. And that would also include other folks in the office, wouldn't it? Wouldn't it include, of course, the dental assistants and the dental hygienists, and then potentially the business office people manning a front desk as well? Do you think N95 is for across the board, or for the people treating patients, maybe in the environment of the aerosols? And then maybe even talk a little bit about the fact that, what we're hearing from people that have actually had to wear N95s, that can be difficult over the long period of a day. And what are your thoughts around that?
2 things. You're 100% right. It is difficult, and we can actually see pictures of healthcare professionals that have been wearing it for hours, and they get sores, actually. That's very, very hard. And the reason for that is they have to be fitted. So that's the second thing. Just wearing a N95 mask without having it fitted correctly is not going to help you as much as it could. So if you start using the N95 mask, you should get fitted. If you change the type of N95 mask you're wearing, you might have to get it refitted again for that specific type. So just wearing the mask is not good enough. They have to be fitted correctly as well.
Yeah, and then what are we thinking about sterilizing masks or wearing something over top of it to prevent, you know, to not have to switch it between patients? Any thoughts on that?
If I was the patient, I'd rather have the dentist switching the mask in between. That's all I can tell you.
And then Mark, I think that's exactly what you were bringing up, right? Which is the idea of donning and doffing PPE all day long between going in and seeing patients. The idea of you know, maintaining concentration to do that in the right order, and then potentially even the amount of PPE we're talking about in terms of waste, but also in terms of cost. Mm-hmm. You know, what do you think about that, Mark?
Yeah, I mean, this has been one of the big challenges that everybody, whether you're a healthcare professional or a lay individual from the public, has been getting a lot of press, and that's the deficit, if you will, of personal protective equipment. And you know, part of the issue is that we have been trained as healthcare professionals for a lot of years, especially in, again, a healthcare environment such as an acute care hospital, that, you know, these are disposable items, and certainly between patients, you're changing them. And going in and out of the OR, you're changing them in and out of other high acuity areas, you're changing them. And so, you know, it may seem wasteful, but that's they're by design meant to be disposable. And so all of a sudden we get to a point where we're suggesting that not only healthcare professionals, but now patients, and now in fact the general public, you know, should be wearing some type of mask in order to, you know, help abate or suppress the curve, whatever language you're using today. I certainly do want to applaud, you know, some of the partners in industry that have stepped up. A lot of people don't know this, but I'll just pick one example, like the Ford Motor Company. So this is completely outside of their area of focus, you know, completely outside of their area of expertise, but they in fact have retooled a lot of their production lines to start producing personal protective equipment. And you know, I do want to just, you know, acknowledge that there's certainly this greater sense that everybody needs to pitch in here, and the prioritization is really around PPE for healthcare workers in particular. But you know, we do have to be cognizant that this is a supply chain that has had a bumpy road, and we need to maintain an intact supply chain in order to keep, you know, our patients and ourselves safe.
Yeah, I think the biggest word is availability here. You know, I think as dental offices begin to restart, cautiously restart, that availability of PPE is going to be potentially a big concern. One last question before we shift gears again. Reusable PPE. What are thoughts around reusable PPE? You know, not just potentially gowns, but also masks. We know about N95s and potentially being sterilized. Any thoughts around reusable PPE? You know, the idea of cloth gowns and then you know, removing them and then laundering them. Any thoughts there, Michael?
I think it's a matter. I think it's going to be a matter of finances. Tell you the truth, more than anything else. You need to set it up. You need to set up your operatory a little bit differently, where you can actually degown and take off your infected or potentially infected PPE within the operatory before you leave the operatory, and then having that collected, being placed in a safe place. Or if you have a gown, the same thing has to be placed somewhere and then sent out to laundry. And you probably have to find someone, either you launder it yourself in your clinic if you have the ability, or you send it out to a place where they are willing to take this type of laundry as well. Yeah. But I think in the end, it's going to come down to finances. I don't think one thing is better than the other. It's like diapers. You're going to use disposable one, or you're going to use cloth diapers. It will be a choice of finance and so on and so forth.
Yeah. Hey, Mark, I want to go back to you on a question that we asked before, which was pre-procedural rinses. I want to talk a little bit about that. And then I want to talk to you about therapeutics for around COVID. So let's talk pre-procedural rinses first. Chlorhexidine, something we're very familiar with in the office. Is that something we should be using?
So in the backdrop of COVID, the short answer is no. I think a lot of us have become very familiar with peri-procedural rinsing with chlorhexidine. Historically, I think that's usually a Paradex, which you know to be 0.12% chlorhexidine gluconate as a swish and spit type solution. On the backdrop of COVID, there is good evidence out there that this is not a product even at the Paradex level of 0.12% that can kill COVID-19, 2019 or COVID-19. In fact, there are very good studies and a position statement by the ADA, the American Dental Association, suggesting that the effective pre-procedural mouth rinse should in fact be hydrogen peroxide. And the percentage is probably a 1% solution. I wanted to emphasize that because the typical solutions available from your corner pharmacy or available through other retailers is usually a 3% solution. So if you are going to be utilizing a pre-procedural rinse, hydrogen peroxide instead of chlorhexidine, you may have to dilute that widely available 3%, by 2 to 1 or 3 to 1 to get down to closer to that 1% concentration.
Yeah, that's exactly what I'm hearing. Any thoughts there, Michael? Are you hearing the same thing?
Yes, there's some other products out there like povidone, iodine solutions, mouth rinses, and there are different countries that use different things. And my biggest problem here is I think we are jumping too early from the lab into clinic. We know things are working very well in a test tube or in a petri dish. Will it work the same way in a patient? There are different issues, obviously, but don't forget saliva is a very, very powerful fluid and can probably neutralize a lot of different things. So I would be careful. I agree with Mark 100% about the chlorhexidine, by the way, because it's been shown to be effective against bacteria, but not really against viruses. So I agree with that one. I would be very careful to rely on it 100%, number one. Number two, if you have an infected patient, and it could be they are asymptomatic, but they are infected, and as you know, they are asymptomatic and still have the virus, the patient is breathing, and the patient will repopulate the mouth during the procedure, if the procedure is long enough, obviously, as well. So doing a pre-procedure mouth rinse, is that good enough? Do you need to do it every 5 minutes, every 10 minutes, and so on and so forth? I don't have an answer. Again, going back to we're building the airplane while we're flying it. We will get more information. But, Jason, you started this conversation with safe dentistry. I think we have to go to safer dentistry. I don't think there is a safe dentistry. And as the mouth rinse is not going to have any detrimental effect, I would say yes, use it until we know better. It's not going to do any harm, obviously. And I think it's good patient management as well. You are taking care of the patient and you are protecting the patient as well at the same time.
Yeah, I think, again, what we're talking about is ways to mitigate risk with the proper PPE, enhanced PPE, potentially testing, potentially pre-procedural mouth rinses. Again, all of these things. I don't think there's a magic bullet, and we can do all of these things to help keep ourselves and our patients more safe. You said something really interesting, Michael, which was the idea that things can work in the lab, but not necessarily work in the patient. And again, I'll go right back to you, Mark, and talk a little bit about what you're hearing on the therapeutic side, things that potentially are working in the lab, but we have yet to potentially see efficacy or benefit in the patient. So I'm talking first around therapeutics and drugs that we potentially could be used to treat COVID-19 patients, and then maybe even on the vaccine side. So what are you hearing there?
Okay. Since you introduced the topic the way you did, I want to tie those two thoughts together, which really what we're all discussing right now is the difference between in vitro data, so, in a test tube in the lab, versus in vivo data. So that would be, in a living organism. And in fact, that living organism, that in vivo, we might even want to take it one step further and say, it might work in certain animal models, but maybe not humans. And so you can even start to parse that out a little bit more. I wanted to start that out because a very topical medication that people are hearing a lot of information about right now is remdesivir. So remdesivir is one of our nucleoside analog prodrugs. It's basically an antiviral type drug. It does have an inhibitory effect on pathogenic animal and human coronaviruses. So an inhibitory effect on pathogenic animal and human coronaviruses, which includes the SARS-CoV-2 in vitro. So that's what I want to highlight, is all of that information is in vitro. In other words, from lab data, we think that it can be effective. It does inhibit the Middle East respiratory syndrome coronavirus, SARS-CoV-1, SARS-CoV-2 replication in animal models. So again, not necessarily humans, but in animal models. And so one of the challenges that we've had just of late is this publication that came out of the Lancet, a fairly well done study, which obviously has gained a lot of publicity. I was almost going to say notoriety, but I'd rather say publicity, that although not statistically significant, patients that did receive this remdesivir did have a numerically faster time to clinical improvement than those who didn't get the drug. In other words, those who received placebo. And so there's a lot of chatter right now that this remdesivir may in fact be a treatment of choice for the treatment of coronavirus. And again, it's really not based on good data. It's based on in vitro data, and it's based on in vivo animal data, but not necessarily borne out truly in humans. And certainly, if to be blunt, what did the study show? Well, if you had a symptom duration of 10 days or less and you were given remdesivir, the idea was that you typically had recovery in 11 days versus 15 days. Again, numerically interesting, but is this something we really want to hang our hat on? I will tell you, as of right now, where are we? May the 6th, 2020. We do not currently have a treatment, a pharmaceutical treatment for the management of COVID disease. And because of all of the work that's being done right now in this particular area of therapeutics, the idea that remdesivir is something that we want to really pursue has been highlighted by the fact that this drug, which has only been available through clinical trials, has actually been granted emergency use authorization by the Food and Drug Administration. Now, it is being still restricted to the treatment of only severe hospitalized COVID-19 patients, typically those on ventilators. Gilead, the company that produces this medication, has donated 1.5 million vials of the drug and is working with the federal government to distribute it to these patients in need. To give you a sense of what that is, the treatment course with this drug is usually 5 to 10 days. And so that's about 140,000 courses. I'm not sure if you think that that's a drop in the bucket or, at least a good start, but that's where we are today. Now, this is some of the most recent information, because it was just released this morning that Gilead has also established an expanded access clinical trial program for this. And they've also designated a specialty pharmacy that's going to be ASD Healthcare, which is a subsidiary of AmerisourceBergen, to distribute the drug. And so if hospitals have these patients, this is not the time to call AmerisourceBergen and say, we need to get our hands on these drugs, because the U.S. government has actually already decided which health systems will receive the donated product based on case level data. So, we've had a surveillance system out there that's being tracked by the federal government, and that's where the dispersion of these medications will come from. It's very interesting, but it harkens back to almost 2-3 weeks ago, where there was some significant interest in the idea of hydroxychloroquine or chloroquine. And I started off my answer telling you that as of today, we still do not have an effective therapy in the treatment of this. So there's more to come. Now, you shouldn't have got me started talking, because I will take the opportunity. I don't normally call out, individual organizations other than, the CDC, the FDA, NIOSH, OSHA. But there is an organization that puts out the medical letter. And so it's available at medicalletter.org. I don't work for this company or, take any remuneration or anything. But the reason I wanted to call it out is because this morning they released a report specifically around this, taking a look at, what therapies are currently being investigated for the treatment of COVID. And so that 26-page report, which normally you would have to subscribe to the medical letter to get access to it, contains such important information, non-biased, non-pharmacy sponsored, that they've made it available to the general public. And so rather than try to give you a very prolonged answer, I would direct your listeners to, again, medical letter, all one word, medicalletter.org. Now, if I was asked to sort of summarize what this 26-page document says, and again, released this morning, so it's as up to date as we are today. Essentially, most authorities recommend the use of these drugs only in the setting of a clinical trial. So they're being investigated, but they're certainly not ready for prime time. And that definitely goes for, drugs like hydroxychloroquine, chloroquine, even the antibiotic azithromycin, which we know as Zithromax. You were asking me with this question, where are we today? Well, there's at least 18 drugs under current investigation, to include over 70 vaccines that are currently being investigated, but we don't yet have that panacea. And so I think it's important to recognize that a lot of work is being done in this area. And hopefully it will lead to an appropriate treatment, but we just do not have that today.
Yeah,
Can I put you on the spot here, Mark, a little bit, take it one step further.
Yeah.
Do you think we're ever going to be in a position that if you believe you have been exposed to COVID, there could be some kind of prophylactic medication that you could take?
Yeah, great question, Michael. And I guess, we're going to have to see how this plays out. I liked what you said at the beginning, the idea that, again, in the lay public, we talk a lot about coronavirus and everybody thinks that there's one, but actually there's many variants. Some are more virulent than others, but, this is a family of viruses. And of course, viruses are prone to mutate. So we'll have to sort of follow the course of this particular pandemic. It may turn out to be very similar to the seasonal flu. Every August, September, October, we're all encouraged to get our flu shot for the year, and we repeat that annually to try to mitigate the opportunity for the flu and influenza to kind of to take a stronghold. And so it wouldn't surprise me if over time we develop a successful vaccine for this coronavirus. And again, maybe it turns out to be when you get your annual flu vaccine, you also get your annual corona vaccine. Or as my partners in the industry will probably develop a penta vaccine or a quad vaccine or something where you get everything you need in one shot. The alternate, if I was to take the more gloomy approach, if this turns out to be much more virulent than we're expecting, in that case, you're starting to look at a vaccine that's going to require significant boosters. And depending on how this vaccine mutates in the future, we may have to be looking at not only boosters, but a change in the formulation for that vaccine moving forward, which means that the ongoing research, development, and ultimately clinical trials for this is going to be with us for a very, very long time. I want to take the bright side here, but there's still so many unknowns right now.
So one quick follow-up, Mark, remdesivir, I'm going to say that wrong, I'm sure, but that's an IV drug, right? That's a hospital-based drug.
Yeah, thank you for stopping me there, because I've already seen in the chat box a couple questions. So a couple quick things. First of all, remdesivir is only available as an intravenous drug, which means unlike chloroquine, hydroxychloroquine, azithromycin, earlier medications that were purported to be useful in the abatement of COVID, this is not an oral medication that you're going to go out and have filled at your corner pharmacy. It really is only for hospital use and currently being very, very restricted or prescribed in who's getting exposed to it. The second piece from the question submitted is right now the Lancet trial was comparing 5-day and 10-day treatment courses in the patients that were shown to be responsive. And there wasn't a significant clinical differentiation between the 5 and the 10-day course. So what I'm trying to say is, most people should probably be getting the 5-day course. Those may perhaps more severe or slow to respond might get a 10-day course. current cost, and because this is not currently available, this is just information that has been passed on verbally from the organization, initially being donated, of course, underneath the emergency use and clinical trial protocols. But it's estimated that a 5-day course is going to be somewhere between $5,000 and $10,000.
Yeah. I'm so interested in the therapeutic side of things, the treatment side of things, and of course, I think vaccines to follow potentially. Michael, your question made me think of something. And again, I have a list of questions in front of me that I'm trying to follow through. You guys are jumping around, so I'll jump around as well. And this one, I think you're so perfect to address. What you talked about to Michael was, in effect, post-exposure prophylaxis or protocols. I know that, and I don't know if everybody else does, but you were on the front lines when dentistry was trying to react to the HIV pandemic. And that's what made me think of this question and want to jump around. The idea of, we have post-exposure protocols for the needle sticks in the office. But I really wanted to get your thoughts around any potential parallels that you're seeing between what dentistry was going through in the early 90s with HIV and kind of what we're going through right now. Again, I just think you're the perfect person to ask this question. So I don't know what your thoughts are on that.
Okay, thank you for that question. Yeah, I think there are parallels. And one of the parallels is I think dentistry is going to change the way it changed after the HIV epidemic or during the HIV epidemic. When I went to dental school, and I'm going to really put myself as an old guy here, I didn't use gloves. And then obviously the HIV epidemic came around and gloves was the thing we was supposed to use. And now to treat someone without gloves, it's feels absolutely wrong. And I think it's going to be the same thing here. We're going to develop maybe new and better type of PPEs. Maybe the suction is going to be different. Maybe the mask is going to be different. Maybe we're going to have some different shields and so on and so forth. So I think we have an opportunity right now to make it even safer to practice dentistry. So that's the good side. But there's another side, and I think it's something we need to address, unfortunately, and that is during the HIV epidemic, those practitioners who treated HIV patients, their practices became stigmatized, meaning, okay, you treat HIV patients, I don't want to go to you because I can get infected. I hope it's not going to happen the same thing here, that, yeah, this practice is known to treat COVID-19 positive patients, I don't want to go there. The argument against that is a rational argument, and as you know, rational arguments don't work all the time. But if I treat COVID-19 patients, obviously I take better or I have better precautions than if I don't know I'm treating them. And as we cannot identify everyone, I would rather go to a clinic that treated COVID-19 patients than those who didn't. But I'm afraid of that stigma. The stigma also associated with the individuals being infected. We started talking, when we started this conversation, about testing. And I think it's a good idea for dentists to do testing for two reasons. One, to know more about their patients, and two, maybe dentists can get involved in surveillance when it comes to getting more information about this spread of this pandemic. What is the denominator? What is it? How many patients really are infected? So that's one thing. But if you do the testing, then obviously you have privacy issues. How are you going to be able to transmit this information safely? Are the patients going to be have some kind of stigma that they're now positive and so on and so forth? Unfortunately, here in New York City, many Chinese restaurants have closed. People don't go to Chinese restaurants because it's a Chinese disease, right? So that type of stigma, I'm afraid it's going to last for a while, and that's very similar to happen during the HIV epidemic. So I think maybe we can take a couple of steps back and look how we mitigated those issues during the HIV epidemic or pandemic, and that would help us to be better, both morally, ethically, and as healthcare professionals during this pandemic.
Yeah, I think you and I would agree that whatever a new standard of universal or standard precautions is, that this will be our opportunity to get to that, obviously. What about, you mentioned testing again, so we'll jump back to testing. You know, you mentioned some of the problems of testing, which is sensitivity and specificity. You mentioned that potentially the negative predictive value can be quite high, and you know, if you're testing for the negative, like hopefully the dental office, you know, that you can be pretty sure that if you get a negative test, that the patient is actually negative. But what I wanted to talk about was a couple of other maybe potentially regulatory issues around testing. First, I want to talk about availability of testing, which is, you know, are these available? Can dentists request them? Can dentists order them? What are you guys thinking?
Well, let me take it first, Mark, and then I'll leave it to you. This is a political issue, Jason, much more than anything else, depending who you listen to. Yeah, we have plenty of tests available, and other people saying we don't have enough available.
Okay.
If you want to test for the virus itself, and you use this PCR, the polymerase chain reaction test, you need reagents. You need something else in order to figure out in order to make the test work. And although we have the tests available, we may not have the reagents available, meaning we can test, but I'm not sure we have the material necessary to get all the answers. And no one really talks about that issue. Most of these reagents, by the way, I don't know the percentage, but I think it's very high. It's close to 90%. These reagents are not produced in this country, produced in China. And even if they did full production today, we probably wouldn't get enough of these reagents to do the necessary testing that is necessary, even though we have the tests themselves available. So that's number one. Number two, when we do the testing today, most of the time we are taking a swab, the nasopharynx or the oropharynx. And how well you can do that, how much virus is available, is going to affect the test result as well. So even if we have a perfect test, which doesn't exist, but even to have the perfect test, if our sample, if the specimen is not good enough, the test is not going to pick it up. That's one of the advantages of serological tests, because you take blood, and if it's in the blood, you're going to find it. But here we're going to specific areas in the body to collect the virus. You're not going to do a bronchial lavage. You're not going to go in and take fluid from the lungs where you actually are really going to find it in a dental office, obviously. So if we perform this test in dental office, or if it's performed at home, it's going to be very critical where we take the sample from. The good news is there are salivary tests available today. And as far as I know, from what I read, at least from what I've seen from the data being produced, the salivary test may be a very, very good option to these swabs that we do otherwise. But I think, Mark, you might know a little bit more about that than I do. And not long ago, by the way, there was a salivary test that was actually approved that can be used, but only for symptomatic patients. And a positive test need to be repeated a second time. But saliva, I think, is going to be the answer to this whole thing.
Yeah, Mark, before you jump in, I wanted to also ask you to talk a little bit more, testing, but also the idea of where the CLIA waiver, CLIA certificates kind of fit in here. Because when you think about dentists doing this test, I've always thought, hey, dentists wouldn't be doing these tests for diagnostic reasons. They'd be more doing them for screening purposes. But according to what I'm reading, when it comes to CLIA, that would still require a CLIA certificate for your office. So I'd love to hear your thoughts on that.
Yeah, and thanks, guys. It's a great discussion so far. So a couple different things. First of all, as a pharmacist, it's always amazing how pharmacists and dentists tend to be very kindred spirits in many ways, because we have also been put at the front lines of this. And in fact, for the very first time, the FDA did mandate about a month and a half ago now that pharmacists could in fact provide testing for this. So it's been, a very significant discussion amongst my profession as well. Very similar to what Dr. Glick was talking about. What exactly do you do with that information? Once you get it, you certainly have a responsibility to report not just to the patient, but definitely to the state repository, because we want to continue that surveillance effort. But you have to be very careful, because unless we have something that is 100% predictive, you know, you could be in Dr. Glick's last example with HIV is a good one, you know, almost stigmatizing this patient. If you happen to use a test that was not 100% perfect and you came back with a positive result and you passed along this information to that patient, whether you're right or wrong, that patient now has to carry that stigma around with them. And, you know, what does that mean to them and their family, their current living situation, how they're seen at work, if they're even allowed to go back to work. So, you know, lots of challenges around there. Now, that's, of course, you know, perhaps a little bit more ethereal than the academic question you're asking me, which really is, well, with the CLIA waive test versus the CLIA required test, certainly the intention as well as, you know, what is the environment registered for is a big issue. I will say that one of the points that Dr. Glick was driving towards, which I can't emphasize enough, is if you are working in a situation where the test you use is fairly POC or point of care, in other words, you do the test and you get the result, that can have very different levels of accuracy. So hopefully we get to a point where those very quick point of care tests do provide the return that we would like to see. But where we've been today, given the reagents Dr. Glick mentioned, is we will, you know, get the sample, we'll send it off, and then the time frame between, you know, when you take the sample and when it actually gets tested also does affect the overall results, and the accuracy of that result can in fact go down markedly from the point at which it was taken to finally run. So there's a lot of general concerns out there. And I think the biggest one, again, from a pharmacist and dental perspective, is it's outside of our purview to diagnose. Certainly it's outside of our purview to diagnose the COVID-19 here. And so I like what Dr. Glick said at the very beginning. In medicine, we never do a test unless you're going to act upon the results. And so are we doing a test in which we can act upon the results? And if we are doing the test, you know, what type of results are we actually providing? That the patient is diagnostic of having something, or simply this is an additional piece of information that we need to pass along, and maybe that needs confirmatory evidence, you know, through a visit with a physician or at a hospital. So again, I think there's still lots of information that continues to evolve here.
When it comes to the CLIA, and I'm seeing in the chat, CLIA would be CLIA. I do not think that there are any CLIA waived COVID tests. Is that correct, guys?
Not to my knowledge right now, yeah.
However, if you have a CLIA waiver already for another type of test, during the state of emergency that we have right now, you can have an emergency use authorization to use this test in a CLIA waived facility. That's my understanding, Mark.
Yeah, that's my understanding as well, Michael. And in fact, a lot of the sort of non-FDA approved tests, they're blanketly putting these under. They're even though they haven't been assigned I'm tripped up there on this. The ones that haven't been approved are still considered CLIA non-waived, or they're still CLIA tests, meaning hospital tests. What I'm thinking about, though, is this CLIA certificate, or CLIA for your office, the CLIA waiver for your office. Do you think that dentists will be required to get this for their offices? I think it's you can go online and do it. I think it's a fee that you would pay to the State Department of Health. But what are you thinking about that, Mark?
I thought you were going to ask the dentist that question.
Well, from what I'm reading, and again, correct me if I'm wrong, but from what I'm reading, the answer is yes, that if you want to actually do CLIA waive tests in your office, you do need to have a CLIA certificate in the office. I don't know if we've always done that, though. And again, I'll go back to Michael after I hear your answer, Mark, but because I know, Michael, you've been an advocate for in-office blood sugar testing, and I know that you and I have done research on in-office cholesterol testing. And so should the office have a CLIA certificate if they're going to be using these CLIA waive tests?
Yeah, I mean, the short answer is yes. Above and beyond just going on the internet, and I think you said you pay a fee, you actually do have to do a little bit of studying as well. So there's some additional knowledge that goes along with this. And I also like what Dr. Glick was talking about in that these tests are not all plug and play. And so, you know, depending on the particular test you may be running, on patients, you do have to get a certain level of training and competency in that, so that you're getting a sample that's going to give you a result that's actionable. Absolutely, it's not just a simple matter of applying, paying a fee, and getting that certificate.
Let me also add one more thing. You alluded to it, Jason. We are right now in a state of emergency. So FDA gives what they call an EUA, Emergency Use Authorization, meaning it's not an approval, it's an authorization to use under the state of emergency rule. So although today we may be able to use some of these tests and even some of these medications, that may change when the state of emergency goes away. And then it's a completely different ballgame again.
Yeah, and I think one good example recently is, and again, it may change from everything seems to change so quickly. You almost have to stay reading most of the day to stay up with all these updates. But I believe the state of Alaska, from the Department of Health, required that dental patients coming in for a procedure that could generate an aerosol must have a negative COVID test within 48 hours. So that's the first state that I'm hearing. What do you guys think about that?
Well, I'm glad that patient didn't get exposed in between the time he did a test and the time he visited the dental office.
Yeah. Yeah, that's exactly what I'm thinking. And I know that there was some talk online about that. Also, maybe it's I don't know if we can really address too much of it, but I know that dentists are concerned about the cost of testing. Who bears that cost? Is that something that a dental office can pass off to a dental insurance or a medical insurance? Yeah, I know that the cost of testing is an issue.
While you're reading your script there, I wouldn't say just the testing.
On the script here. You're looking for the questions.
I will also say, so you go ahead, you read your notes, but there's also a lot of chatter right now about the PPE as well. So perhaps increasing your fees to cover the cost of additional personal protective equipment in managing these patients. So yeah, there's no end to what these additions are going to do.
And I know that I believe that the American Dental Association has instructed dentists to use the code D1999. And so that's interesting that that's out there. I have more questions, just reading down the list here. Mark, let me go to you and tell me about ibuprofen. If we have a patient who has fever and they suspect they could have COVID, I know we heard a lot about ibuprofen. What's the latest there?
Sure. So two things, I guess, to frame our discussion properly, because I think, your first question is really, is there evidence to suggest that ibuprofen, or let's just say any of the non-steroidal anti-inflammatory drugs, can be harmful in the setting of somebody that has a respiratory infection? And so let's just start with respiratory infection. In fact, there was a very well done review recently taking a look at patients suffering from community-acquired pneumonia. So that's a bacterial infection. This is not a viral infection. And what they did find was that it's possible that the use of non-steroidal anti-inflammatory drugs could, in fact, lead to a worse outcome in these patients, primarily because the effect is that the non-steroidal anti-inflammatory drugs, such as ibuprofen, can blunt the recruitment of what we call polymorpho nuclear neutrophils. In other words, those PMNs that are going to come and help to clear the infection. And so the non-steroidal anti-inflammatory drugs can, in fact, in some of our worst of the worst community-acquired pneumonia patients, certainly, hampered their improvement. Now, I want to jump from that because that's usually what we're thinking about, but you were specifically asking about COVID patients. So now we're talking about a viral type respiratory illness, and that is one of the early reports that came out, and it started with 4 very young individuals in France whose prognosis after being diagnosed with COVID was very grave. And the one commonality was that they were all on ibuprofen. And so the resultant headlines, of course, were if you have COVID, don't take ibuprofen because, essentially it will kill you. And while there was a temporal relationship and a commonality, that was not necessarily cause and effect, certainly not in a sample size that small. Since then, there's been additional, scientific reviews of this, and the thought is still kind of speculative, but the idea that SARS COVID virus actually enters our host cells through an angiotensin converting enzyme 2, or ACE2. And when you give somebody an ibuprofen, a non-steroidal anti-inflammatory drug, they can actually increase the expression of ACE2, which may facilitate, the entry of the virus into the lung tissue, and perhaps causing a worse downstream effect. I will tell you that this article that was published in Lancet Respiratory Medicine just a month and a half ago now stated that ibuprofen clearly increases the ACE2 expression, but no reference was actually given to that statement. So unfortunately, I just don't think that the evidence is there, and certainly if you take a look at some of our thought leaders, so now I'm talking about the World Health Organization, the Center for Disease Control and Prevention, the US Food and Drug Administration, currently they are all consonant in their recommendation, which is not to stop using non-steroidal anti-inflammatory drugs in the setting of COVID-19. Even the updated Surviving Sepsis Campaign guidelines suggest that ibuprofen still be considered one of the drugs of choice. Now, again, I really appreciate this question, because normally the questions that I get from dentists around about dentistry and medicines in particular is, how are things going to change sort of post-COVID? The nice part is that dentists don't really prescribe a lot of medications. And so, we don't have to think too far afield here. More importantly, when dentists prescribe medications, it's very episodic. In other words, you're not prescribing medications for chronic conditions that patients could take for the rest of their life. And so as we take a look at this, first of all, based on, let's say, a short analgesic prescription for postoperative dental pain, we already know the guidelines are very clear that acetaminophen coupled with ibuprofen should be considered that combination of choice. And based on everything I've told you so far, acetaminophen and ibuprofen, very, very safe, even in those patients that are positive for COVID. So that's great. Nothing is going to change with your prescribing practice to manage postoperative dental pain. The same is going to be for intraoperative pain management. The use of local anesthesia does not change in the face of COVID. And we have excellent guidelines on the prophylaxis of patients utilizing antibiotics. And that also does not change in the face of COVID, whether it's for prophylaxis or treatment of an orofacial infection. So all of these things are very, very positive. Now, some of the ones that could possibly change, we spoke already about the idea of mouth rinses, perhaps switching from chlorhexidine to the hydrogen peroxide 1%. So that could be a practice change. But in and of all the therapeutics that dentistry currently uses, COVID is not going to change this. The last one I'll make a comment on, and Michael, I'm going to preface this, so be prepared. I'd love to hear your thoughts around this. But I've been asked a lot of questions around about the use of nitrous oxide. So nitrous oxide often used as an inhalational sedative agent for patients to get them to relax in order to accept dentistry. Since the primary transmission of the COVID virus is through aerosolization, people breathing back and forth, perhaps. Is nitrous oxide something that has run its course and should not be used in dental offices anymore on the backdrop of COVID? And again, that's just not necessarily true. The machines have disposable parts, which of course we are changing between patients. The parts that you're not changing could certainly be autoclaved if that was required, but they really shouldn't need to be autoclaved between patients, because you are working with a gas that is under positive pressure. It only goes through the system in one direction. It's also set up with one-way valves to prevent any type of backflow. And I will tell you, the manufacturers of these machines, whether we're talking about central systems or the portable systems, are held to very, very strict guardrails. And these fail-safes are put in place to stop the potential transmission, aerosolization from one patient to the next. Now, I understand if you're a patient walking into a dental office and you're wondering if COVID positive patients have been seen here, and then the dentist is about to put a mask on you that perhaps another patient had used. Sure, I think we're going to have some challenges in our patient management, but please know that nitrous oxide is going to be as safe today as it was last year and a year from now. So with that, I know it's a long drawn out answer, but very important topic. And Michael, I don't know if you have any comments around that too.
No, but I think you brought up a very good issue with the one way when it comes to using nitrous. Don't forget, there is a some retraction of saliva into the system when we treat patients as well. So following the regular infection control procedure, meaning rinsing and being able to flush through the lines, is probably going to be even more important right now than it ever was before.
Yeah, thank you.
So as I wind down my list of questions, I have a couple of last ones that I want to put you guys on the spot with. Now, I want to get practical for a moment. And I want to ask you guys, of all the things we've talked about or things we haven't talked about yet, any specific, we started off by talking about the playbook to get back to work. I mentioned the idea of preoperative interviews and taking temperatures and, waiting in your car and, social distancing in the office. Any best practices that we haven't mentioned for dentists as they begin the re-entry process? Protocols or procedures that you guys may think about that could potentially be effective during this time? Michael, any thoughts?
I think we're entering an era of not a new normal, but a new abnormal. We are going to see dramatic changes. Just think about operatories that are open operatories, and you have several in an office. How are we going to now see patients that are very close to each other and use aerosolize? I tell you what, one of my biggest concerns are actually hygienists, obviously, because of the Cavitron. Are we going to see hygienists now using less and less Cavitron and doing hand scaling than they did before? And what that's going to mean, what will that mean then to the patient flow, as an example? Another thing is the patient then going to be seen by the dentist who's going to use aerosol to check and so on and so forth. I think we're going to see a lot of these changes. Mark mentioned also this COVID pandemic that we're in right now, and we talked a lot about it. I think we have to realize that this pandemic, if it's going to wane down, we're going to end up with an endemic disease. It's not going to go away. We're going to have it. And if it becomes endemic, we're going to get used to it. And my concern is that if we get used to it, we should still respect it. We shouldn't lose respect for this very, very deadly disease. And the problem is when it becomes too common, we may actually lose respect for it and do stupid things. So my best advice right now is make smart decisions.
Yeah. Hey, Mark, any thoughts? And when I go back to you, I wanted to highlight one thing you talked about, which is nitrous oxide. And some folks use portable nitrous oxide units. And you mentioned the idea of parts that can be changed, parts that can be autoclaved. But, barriers, the idea of simply covering things, I think, is also something that I think we're going to be moving towards. And, taken to an extreme, I can envision a dental office with everything covered. And I'm sure that's part of the nitrous story as well. But any practical thoughts around things that dentists and dental teams could be doing right now?
Well, I think most offices, on a regular basis go through some type of deep cleaning. You have your housekeeping service coming in every night, but maybe on a weekly, monthly basis, whatever that looks like, you've typically had this sort of deeper cleaning. And I think that is going to get stepped up quite a bit. I think that the fact that universal precautions may in fact get stepped up. We talked about the N95s. I think all of those things are really going to change practice. You had initially asked both Michael and myself how we perceive dental practice to change. And, I really have no business talking about that. I'm not a dentist. But I will tell you, because I know Michael has brought this up before, that there is a big impact here. I mean, we've seen some of the unemployment numbers that have come out. And I will tell you that the face of dentistry certainly is going to change, but the face of your patients are also going to change. And listen, if people have not had paychecks in a long time, oral health and visiting the dentist is not really high on their list. And especially if they have this stigma or fear that they may be going into an environment where, COVID positive patients have been, and this could be a loci for, me to get a potential infection that I've been able to stave off so long. I mean, there's a lot of significant social challenges around this. I don't know what the answer is, but lots of things for us to consider.
Yeah, and that kind of brings me, thank you for the segue, Mark. That brings me to one topic that I want to make sure we cover. It's one of my very last questions for you guys. I've got maybe a couple more, but you're talking about what patients may read about dentistry. And, you know, I think we've discussed a lot of great resources tonight, but unfortunately, I think that there's a lot of misinformation out there around what could potentially be going on maybe and during the pandemic as a whole, but also around dentistry. And so maybe I'll ask Michael, what are your thoughts around misinformation right now? You know, where there's an avalanche of information every single day, and, you know, it takes your whole day just to keep up with it sometimes, but the quality of information is what I'm asking about.
Well, people want answers, and that's obviously very understandable. People don't like uncertainty. That's also very understandable. So they hang on to things that will make them feel much more in control and more certain in what they're doing. We have to be much better critical thinkers, and we have to be able to parse the facts from the fiction much better than we have. There are hundreds and hundreds of websites out there today spreading conspiracy theories about you can do this and you can do that. You can boost your immune system. If you take this pill, you know, you cannot get COVID-19, and this mouth rinse is perfect. You know, I used it on a patient and I didn't get infected, and so on and so forth. I think we have to be very, very careful with all the information that we are getting here right now. And I think Mark made the classic example. We heard on television how this new medication can actually reduce the recuperation time by 4 days. It was never mentioned that this was never done in humans. So it's not misinformation, it's the lack of all the information that was given to us. The same thing with hydroxychloroquine. It was promoted by some of our leaders. Suddenly there was not enough hydroxychloroquine or chloroquine available for people who actually needed it. And then a VA study came out and showed that if you give this medication, it's not going to benefit. It might actually be detrimental. So that became the story of the day. But that one never went through peer review. So here you have another story that it might be true, but hasn't gone through peer review, the scientific peer review. So can we trust that one even? I think we're in the middle of a tsunami of information right now. There's no question about it. And there are certain websites you can go in actually and look at these type of information. But I did a very quick, I like numbers, and I did a very quick calculation. There's one new article on COVID coming out every 11 minutes right now. There's no way. Jason, you said you spend the whole day, you may spend the whole day doing it. That's not enough. You have to get up a couple of hours earlier even in order to spend your time doing this whole thing. We have to be able to become better in parsing the facts from the fiction. The misinformation out there is detrimental, and I don't think I'm pushing it too far when I'm saying it actually, it will kill people.
Yeah, Michael, it's such a great point. And let me piggyback onto that, because one of the other things that has been in the news of late, of course, are ventilators, right? We don't have enough ventilators, and, you know, there's been this big push to in fact create a national ventilator program, which was announced by the White House a few weeks ago. Well, everybody is now up in arms, you know, how can we get more ventilators? But I don't think anybody sort of hit the pause button to think, how do these things work? Because you need drugs to give to patients before you put a tube down their throat. And typically that means sedative agents, neuromuscular blockers, paralytic agents. And believe it or not, even if we had all the ventilators today that we need, we don't have all of the paralytic neuromuscular blockers and sedative agents that we need. There is a significant drug shortage right now. The analogy is being made of, you know, you have a great car, but without gasoline, you're not going anywhere. Now, a lot of the wholesalers, medication wholesalers, pharmaceutical companies are working as fast as they can to mitigate this problem. But, you know, we think that there's a problem, we think that there's a solution, and we run with it. And not enough thought has been put toward, as Dr. Glick said, you know, the bigger picture, and making these critical decisions that require, you know, good input. And the misinformation is just it's unfortunately making us kind of run around in circles sometimes, and it waste time. And in this particular disease, we don't have a lot of time to waste.
Yeah, and I want to go back to something that Michael said along in the beginning of our discussion, which was that, and it relates to the idea that do we have data on the transmission or in the infections within the dental community, within the dental profession? And you said no, we don't have that yet, right, Michael? Hopefully that data is forthcoming.
I hope so. I hope it will
Yeah.
be forthcoming. We are looking for clusters, and I presume someone will publish it as soon as they have a cluster, because it's very easy to get things published now today, so they can have a very quick turnaround time. And I tell you what, I'm astounded that we haven't got that information yet. And to me, that only points to it probably is a rare occurrence, if anything. But will it happen? Yeah, and that's why I talked about safer dentistry and not safe dentistry. Yes, we will have, but be very careful, because it happened in one single setting at one place where they used special PPEs and not special PPE and so on and so forth, and then generalize that to all dentists. We have to be very careful with that as well. So translate, even if we have now clusters, let's say, to translate it to, should everyone change? Should we all have negative pressure rooms? Should we all sterilize everything differently and so on and so forth? The bottom line is we still have to practice dentistry and we have to see patients. And if it's not going to be possible to see more than 1 or 2 patients or every 2 hours, it's not going to be financially viable even to treat patients. So we have to come up with different ways of doing this whole thing. Yeah. We still need to treat patients, and when you have to do it in a safer manner than maybe we did before. But don't dismiss the financial aspect of this whole thing. This is going to have a tremendous impact on dentistry, no question about it. But be careful, don't go too far, because I think if you overdo it, it might have a negative effect on another aspect.
Yeah, I think what I'm driving towards is, and I think you feel the same way, I think, based on our prior conversations, is that that data would be very useful to help inform us how to stay safe. It is the level 1 or 2 mask, or the N95, or the air purifiers, or what do we need to stay safe? And I don't think we have that data yet. Again, I want to put you on the spot, guys, and I want to go to Mark. Thinking about where we are today, is there anything in particular that you're encouraged by? Some piece of good news that that resonates with you, or something that makes you just more discouraged? You know, maybe something good that you're thinking or seeing or reading, and maybe something that you're a little worried about.
Well, I think one of the things that, you know, gives me hope is that this is something that has been embraced by everybody. You know, this is not a healthcare alone issue. There are other organizations that have really stepped up to try to help. I mentioned the Ford Motor Company, you know, retooling their production line to start producing N95 masks. Other companies in different sectors outside of healthcare that have sort of stepped up to help in the development of parts of respirators and things like that, or ventilators. So I think the fact that everybody is sort of swimming in the same direction, you know, that gives me hope. In the same vein, I also think the fact that, you know, we have at least 70 vaccines under investigation right now, you know, also makes me realize that this pandemic, which is worldwide, is something that, you know, everybody is focused on. You know, at the end of the day, whether we're talking about bacteria or viruses, they were all here before us, and they will be here long after us. And if we want to, you know, be here on this planet for an extended period of time, we are going to have to all work together. What's disheartening? I think we just covered the disheartening part. I think that there is so much misinformation. You know, the internet is good for some things, but it's just horrible for others. And it's just far too easy for people to post opinions more than anything else, certainly not hard-based science, evidence-based medicine, and to have other people pick that up as fact and propagate that. And that can arrest our forward momentum, which is a significant challenge.
Yeah. Michael, any thoughts about what you potentially are encouraged by now or discouraged by?
Well, I'm encouraged about the interest as well as the participation of everyone. It's become not a dental issue or a medical issue. It's become a public issue. And I think if we're going to change The public needs to be involved, and I think the public in many ways is going to drive these changes. So in many ways, I hope that these changes are going to be positive, obviously. And I think in all crises, there are opportunities, and I think we have opportunities to be a better healthcare professional than we were before. And we should take this opportunity and embrace it, I think, in order to do better than we have done before.
And anything you're discouraged by?
Well, what I'm most discouraged about is this misinformation, to tell you the truth, that people sort of are hanging everything and all the hope on all this misinformation out there, and they get discouraged and they get disappointed. And it's even worse than that, have even more dire effects than that. Unfortunately, that's who we are as human beings. You know, we try to do our best, and sometimes it's not good enough, unfortunately. But I think, again, we're learning how to do this better, and that is very, very good. If we can learn some lessons from this, because this will happen again. This is not the last pandemic that's going to hit us. That's going to happen again. It's almost every 10 years we get something. So there's going to be again, and I hope we as a profession and as a country will be better prepared next time.
Yeah. So as we wrap up, I want to actually go to Mark and then Michael again and talk, we'll ask you, we've covered a lot of ground this evening, and Michael, to your point around interest, this Zoom chat is just amazing. So many people are participating, and I know that we've had a tremendous sign up and a tremendous participation this evening. But is there anything that, Mark, you're thinking about that we haven't spoken about? Anything that you're thinking about that we haven't covered this evening?
No. we can be comprehensive. You know, I would say for my part of the world, which really focuses on therapeutics and you know, the medicine piece, we've talked about lack of treatment today. We've talked about, you know, the investigations towards a panacea, which could be a vaccine. And then we've also talked about the potential for post-exposure prophylaxis, and all of those are potentials. But there's a lot of bright minds, bright labs, bright companies that are working on this as quickly as they can. And I agree with Michael. I mean, you look at history, you know, we've had, 10 pandemics in the last 100 years. So we really do have one every 10 years. And we need to get better at learning from history so that we don't repeat it.
Mark, when you said you're part of the world, I actually thought you were going to talk about Montana. And, you know, I think it's worth noting that, you know, Dr. Mark is joining us from Whitefish, Montana, and Dr. Glick is joining us from New York City this evening. So it's great to be able to get everybody together. Michael, any thoughts, anything that we haven't covered that you think is worth bringing up?
I'm afraid of mentioning anything, to tell you the truth, at this point in time. But I think as a recovering dean, one issue we haven't talked about is education. The effect it's going to have on dental education is going to be enormous. And I hope that we will have an opportunity some other time, maybe, to talk about that.
Yeah, I mean, I think, yeah, that's maybe a whole nother webinar we'll do another time on the topic. But yes, I think that's, you know, from the dental school to the hygiene schools to, yeah, so yeah, good topic for another time. So I'm looking at the chat, and we've been trying to address questions as they've come up. But before I say thank you to everybody listening, I really want to say thank you to each of you. I know that we've taken about an hour and a half of your time this evening, and Michael and Mark, I just want to say thank you for participating. And this came together pretty rapidly, and your insights, I think, are wonderful. And if you guys are following along with the chat like I am, we're getting a lot of nice comments from people that they enjoyed the webinar. So as a wrap up, I want to say a thank you to everybody that's tuned in.
Premier Dental, Inspired solutions for daily dentistry.